All right, another Thursday on the docket. Let's get going. Yes, there's a little bit of a video error, but you'll still be able to hear me and we'll still be able to go through these. So first up, from the Clinical Journal of Pain, the relationship between pain catastrophizing, kinesiophobia, central sensitization, and cognitive function in patients with chronic low back pain. So what they wanted to do is they wanted to see if your cognition, your ability to think, do, perform, remember, was affected in any and all ways around chronic low back pain. And in this small sample size, they kind of made that illusion. So a sample size of 60 participants with a pretty wide age range with chronic low back pain completed various metrics. So pain behavior measures, so how much did they catastrophize their pain, how much were they scared of it, how much were they going to doom and gloom into it and avoiding things. Um, Going right into the kinesiophobia scale, kind of the same thing. Central sensitization, so how much do they think it is stemming from their brains? So actually, let's back up. So central sensitization basically means that rather than having an obvious pain generator, like if I cut my wrist, the cut and all of the associated nerves and things around that wound are what's generating the pain signal. We can think of the brain as kind of like a dial mechanism of how much does it pay attention to? Does it turn up the pain signaling? Does it turn down? It's essentially the software that puts either the brakes or the gas pedal to it. So central sensitization basically means how much are they putting, the gas to the floor, like feel the pain all the time, and it's not as much about the actual injury down at the wrist versus how much is it putting the brakes on. If we want to think of this conceptually another way, if all of you listening to this right now, picture yourself taking a fresh piece of paper and cutting, giving yourself a paper cut on your fingertip, that is, objectively speaking, a very minor injury. But holy smokes, does it hurt a lot, because it's around a lot of pain center, or not pain centers, a lot of nerve centers, and your brain, without having to worry about anything else, can focus on it. So it dials up the pain. Compare that to, some of the stories you hear from, untold stories at the ER or anything else like that. A lot of people going through a major injury don't really feel it. Well, it's because the brain doesn't have time to feel the pain, so it just doesn't choose to feel it at that time. But that's essentially a 1,000-foot view of central sensitization. Then they compared that to cognitive performance tests. And what they found is that performance was positively correlated in the metrics that they measured, which means what? Well, what they really thought that the taxing, the mental taxing that your brain goes through on a subconscious basis may play out in a conscious way. So put another way, if your brain has a limited number of resources and it's already going through everything that it needs to go through managing a chronic painful condition, it may not have as many resources available to actually put forth and do the conscious things you want it to do. Ergo, your performance went down when they were studying it. So what did they really see? Well, it was attentional interference, inhibitory control, set shifting, and sustained working memory functions were affected in those who had chronic low back pain versus those who did not. So these deficits have potential to influence how patients respond to therapeutic interventions with a cognitive focus. So if we're trying to educate you, if we're trying to put you through a chronic something that shows to have benefit in chronic low back pain, which is cognitive behavioral therapy. So it may be something that is, for lack of a better word, a missing piece is, yes, you have chronic low back pain. Yes, you're doing everything physically for it, but maybe there's some mental pieces that we can just either expedite the process or pay attention to give you a better walk on life. But we've got 4 more studies. These are relatively short, so let's just keep the ball rolling. Long-term effectiveness of non-surgical interventions for chronic low back pain, a systematic review and meta-analysis. Basically, what was this one? Oh, yes. So systematic review from a bunch of different databases were searched up and through May 22nd of 2024 for randomized controlled trials assessing non-surgical interventions in adult with chronic low back pain. So they wanted to have studies that assessed pain intensity outcomes, disability, long-term, very long-term, etc. Comparators included placebo, other interventions, no interventions in usual care. And what did they find? 75 trials of 15,000 participants were found. Risk of bias is rated very high in a majority of studies, so 51 out of 75 or 68%. In people with non-specific chronic low back pain at long-term follow-up, there's a decent level of evidence that cognitive behavioral therapy, well, look at that, we found that again, and mindfulness probably result in reductions in pain intensity. And where was it? And here we go. And disability. Goal settling, goal setting, and needling probably reduce disability at long-term follow-up. Low certainty evidence that multidisciplinary care could reduce pain intensity and exercise might reduce disability at very long-term follow-up. Now, again, that's just one review. That's their databases and that's their conclusions, which frankly matches up with a lot of other studies we found. There are other interventions and other clinical guidelines that show us that non-surgical intervention is essentially the staple on how we need to approach chronic low back pain and low back pain in general, with only a few caveats. So if you have a catastrophic injury, if you have significant legitimate instability in the spine, some neurological disorders where they actually have to get into the spinal cord for various reasons, those are what you reserve surgery for. Um, and it's really key that we make sure that we educate people and educate clinicians on those guidelines and on these studies that essentially reinforce one another in what they're saying. Um, the actual mechanisms behind people being in pain and chronic pain are so variable, so widespread, and can touch so many different aspects and facets of their lives, including their biology, psychology, environment, nutrition, chemical status, genetics, etc., that always defaulting to a high level intervention such as surgery, whether you need it or not, can bog down the actual system and reduce access to people that legitimately need that care. Now, having said that, there's also, there's a bright light. Like what do I do now? I thought this was the route that I needed to take. Well, it is so widespread that it's both a blessing and a curse that you just have to find what is going to be the best first steps for your own brand of low back pain. So in the ones that they actually put through research studies in their findings, some things were cognitive behavioral therapy, mindfulness, goal setting, needling. Other studies can include other non-surgical interventions such as manipulation or mobilization. It can include various soft tissue modalities ranging from massage to instrument-assisted work. Exercise is always a staple in these, always has been and always will be, because even if it's not directly benefiting your painful experience, it is making you more robust and able to handle challenges in the future. So there are dozens of things that you could do. It's just a matter of finding somebody who can help guide you, play um, quarterback, and figure out where do we start with your brand, what is meaningful in your life, what do we need to get back to, what is your pain levels like, what are you capable of. Like, there's so many questions to actually answer. You just need to find somebody who's taking an evidence-based viewpoint through this, playing quarterback and figuring out what's the best for you at this point, at this time, right now for you, rather than defaulting to, hey, you have back pain that I don't like, get out of my office. So that's why I wanted to include this one, was just to have a little talk on that. Last three studies, pretty quick. Correlation of core stability and isokinetic strength of internal and external rotators of the shoulder in university level players. This one, we don't really need to get into this so much. I'm not really going to tell you about isokinetic machines, what is isometric versus isokinetic versus, we don't need to get into that. Suffice it to say, they were measuring strength on a gold standard tool, and what they wanted to see was if there was a correlation between trunk stability and their results on that force measurement tool. And surprise, surprise, there was. The more stable you are through your torso, the more you're able to transmit force into that shoulder. Put another way, if we just kind of lock you down in 1 sec, every single time. Apologies. Got to update my settings yet again. Where was I? Oh yeah. So if we basically pin you down and tell you to only use your shoulder, you have no other ability to use any other musculature whatsoever, you're going to be humbled pretty quick. Anybody who goes to the gym, you can bench 2, 3, 4, 500 pounds. You can squat 4, 5, 6, 7, 800 pounds, whatever it is. But as soon as you start going into shoulder exercises, um, shoulder accessory exercises, because we're going to exclude those people that can overhead press like 400 pounds. But they humble you really, really quick. They basically, rather than reaching for the 50s, you probably reach for the 20s. The shoulder muscles, if you isolate them entirely, aren't nearly as strong as we want them to be. I always want them to be stronger, mind you. But when it comes to force generation, you're able to do a metric ton with our arms because of mm, the way the shoulder itself is set up. Let's take, rather than a bodybuilding or weightlifting perspective, let's take a baseball perspective. This might be better. If we tell you to basically stand still, straight on towards the home plate and throw the ball, it's not going to be very fast. Versus a pitcher where they're able to wind up, push off with their feet, use their torso to torque and turn, and then release the ball with their arm, that ball can whiz at 100 miles an hour. So it's all about force transmission. And if you do not have a torso that has the adequate levels of stability, endurance, and control, you may not be able to transmit as much force into the shoulder when it's being tested. So this is really, really useful when, in particular, we're talking about athletes or ballistic and dynamic individuals. But it can also play a role in, how do I phrase this without getting into another talk? It can also play a role in why you have to take a whole body approach, even if you have an isolated joint issue. Ergo, even if you just have a shoulder issue, if I'm not doing a good job and improving your whole system, I could spend a year just beefing up one shoulder, but if I don't build up the rest of your system, you won't be able to use what we built up. So that's why it's important to take a whole person, whole body approach, even for, oops, I'm on the wrong study when I'm talking about this. Even when we're talking about isolated issues, you got to take a whole body approach. Last two, clinical outcomes of combined focused shockwave and ultrasound guided percutaneous irrigation of rotator cuff calcific tendinopathy therapy. What the heck did I just say? Well, they wanted to measure a tool, specifically shockwave therapy. And yes, they did combine it with an irrigation technique already used in medicine to see if not just tendinopathy, but calcific tendinopathy. So this is where actual calcium deposits can form within the tendons themselves. And it's like trying to, if you really want to think of it, it's like a kidney stone of a tendon where you basically have this hard object where it shouldn't be anymore. So how can we go about treating it in a as conservative a way as possible? And can shockwave, because it's used in other medical interventions, like with kidney stones, there are some that you can do a directed shockwave and hit it and break it up. Can you do that for other areas in the body? And yes, you can. So once they put the patients through, where they, I think it was 4 to 6, let's see, 229 patients experienced shoulder pain, blah, 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 blah. They had that calcific tendonitis, mean age. They wanted to measure resorption rate, how many treatments it took, clinical scores, etc. I guess it's going to be right in the results. Complete resorption occurred in a majority of the shoulders that they put that they had go through this intervention. Partial resorption was observed in 38 shoulders, and no change was noted in 4 shoulders. So you had a pretty good chance of having something happen, for the benefit. The mean number of treatments was 4. Wow, that's really good, especially over that time period. Their scores, and they measured them between pain and ability improved. Number of treatments was markedly higher in a subclassification of this calcific tendinopathy. The complete resorption group exhibited better scores and required fewer treatments. That makes sense. So it looks like this is something that if you have that subdiagnosis of tendinopathy, on top of already having a great outcomes for normal run-of-the-mill tendinopathy as far as Shockwave is concerned. It looks like it can also be used in conjunction with that ultrasound-guided irrigation for calcific tendinopathy. So something to keep an eye out for when you're looking at different potential treatments, non-surgical treatments for some of the things that you people may have out there. Last one. I wanted to end on this one. The EMU manipulation study, a randomized trial investigating the efficacy of matched or unmatched cervical thoracic manipulations on neck pain. So we can basically just leave it at the title page and highlights, and that's really all we need to know about it. First up, what is matched and unmatched? So they wanted to see if matching pain sites to the adjustments at hand improved symptoms, or if they flipped them on them. So if you had neck pain, would a neck pain adjustment help? Or if you had neck pain, would a thoracic adjustment help? So matched, neck pain equals neck adjustment. Unmatched, neck pain equals thoracic manipulation. And I even believe they did it for upper thoracic pain, matched versus unmatched. I'm sorry, I'm just double checking this and then go back up. Quadruple, two-arm randomized, 40 participants, completed a bunch of different metrics so that they could measure them. They are each equally allocated to a single session of either matched or unmatched manipulations based on those results. And pain and range of motion were assessed immediately post-manipulation in a majority of the participants at 1 week follow-up. Significant differences, pain, yeah, looks like it's not gonna have to go through and figure that out after this recording. But basically what they found was it didn't really matter which one you did. Everybody improved. So we can essentially be a bit more patient-centered when it comes to choosing where to manipulate for these people. If you have neck pain, for example, if you have neck pain, but you're a bit skittish about getting your neck adjusted, this is actually fantastic news. And it's something that I've done with a good chunk of my patients, where we stop once we get to the neck. We'll adjust the rest of their body that they're comfortable with. We'll adjust all the way up through the mid back and even the upper back. And we still get great clinical outcomes, and we don't have to touch their neck and do anything outside of the patient's comfort level. It's also something where we get to really make sure that if we're selecting an intervention, it's going to work for other categories of issues. For example, there are certain conditions that I would look at the study and say, well, I'm still adjusting the neck. And that would be for cervicogenic vertigo, if it's adequately diagnosed, as well as various types or subtypes of headaches like cervicogenic headache. Because of the potential mechanisms at play, I can reserve on when to pull the trigger on actually going into the neck if I so choose, which is also another pro. One other is then I also get to reserve adjusting the neck for those people that just, as long as it's safe and an adequate exam was done, save the neck adjustments for those people that just feel that they need it, because there is that patient experience that plays into it, a variation on the placebo effect, essentially, where if I don't touch their neck, then they're not going to get better, plays a big role into how some people recover, which means we can have that discussion at that time and make sure everything is, green light go, that we're matching the therapy to the patient. So it says random, it says unmatched, but this actually lets us be more patient-centered, even more patient-specific with, paradoxically less specific interventions. So I'm just going to, read the highlights to kind of end this video. Efficacy of cervical and thoracic manipulations did not differ for neck pain. Manipulations based on cervical thoracic differentiation testing were not superior for pain relief. Basically, can you try and pick which one between the two is going to have a better outcome? Both cervical and thoracic manipulation yielded pain relief beyond during provocation motion. And relief of pain during provocative motion persisted at 1 week, regardless of region manipulated. So I love these studies. I really, really do. It lets us show patients that if they're skittish because they have a predetermined, hey, I have neck pain, therefore I'm getting my neck adjusted, we can help these people. It lets us self-select to the people that really would benefit from cervical manipulation even more. So it lets us have conversations. It lets us be more broad in our treatment, save those who really need neck adjusting for those who need neck adjusting, and lets us be even more patient-centered and matching care to the person in front of us rather than the intervention to the patient. So